Thanks everybody for coming to another weekend session of GlomCon. My name is Dr. Simon Walker. I'm a renal pathologist in Calgary, Alberta, at the University of Calgary Foothills Medical Center. And today we're going to be hearing from Dr. Jesper Kers, who's a renal pathologist in Amsterdam. And the session is titled Preparing Image Analysis Tools as Clinical Decision Support Systems in Kidney Transplant Pathology. And with that, I'll pass it over to you, Dr. Kers.
Sure. Thanks for having me here on Sunday. I hope it's nice to see so many people actually join at this time. So I'll be talking about some recent work that we've been working on in my lab. So this will all be on computational pathology, applied to transplant cases. Let me see if I can. Yeah. So a bit of the outline of my talk. We will talk about some of the limitations of the current BANF classification system. I assume that most of you are familiar with the fact that we're using this classification system to grade and stage our transplant biopsies. We'll go through some of the recent advances of computer vision as a potential solution to overcome these limitations. And I will introduce some very, very recent work on a suite of clinical grade algorithms we term BANFnet. And I will walk you all through that. And at the end, we'll end with some concluding remarks. So maybe to start off, this is probably familiar for all of you. We are using this BANF classification system to assess all kidney biopsies, basically. We assess multiple lesions in different compartments of the kidney. We grade inflammation, we grade fibrosis, we grade damage on an ordinal scale from 0 to 3, representing these thresholds that you can see here. That is nicely summarized in this paper by Candice. But there are some inherited problems with this classification system. It's quite complex, the interpretation. You need a certain level of expertise to do that. These thresholds that you can see here are arbitrary and they're semi-quantitative. So they're not quantitative assessments of the biopsy like you would have, for instance, for a blood test. So you have always this score is always on this scale from 0 to 3. And that makes also that there's disagreement or dissension amongst pathologists grading these grading biopsies. So when you ask multiple pathologists, it might be that you end up with different grading for the same biopsy. You can see an example of the complexity here. For instance, this is a T1 versus a T2 lesion or tubulitis. You can see here the tubules with inflammatory cells. And when it's the number of inflammatory cells for one of these tubules crosses, let's say, a certain threshold, you grade it higher or lower. So, of course, I mean, there are like 2,000 to 3,000 of these tubules in each biopsy. It can be very focal, and that makes it sometimes complex. And also, for instance, there are scores like peritubular capillaritis. For instance, here, it's a combination actually of multiple thresholds. And so you have to score that more than 10% of the capillaries are involved in inflammation, and then you can actually grade them according to the number of inflammatory cells in the capillaries. So these are quite complex scores if you think about it. Then if you have all these scores, you have to integrate it into a diagnosis. This is from a recent paper from the group in Paris. They nicely put it together in a decision tree. And you can see here that there are actually multiple combinations of these lesions that lead to exactly the same diagnosis here. Of course, this biopsy can look completely different. So that's important to remember. So this is, in fact, a complex system. It's very prone for error. And that's actually the reason why they published this study, is to try to automate this decision tree and help pathologists grade their kidney biopsies when they already assess these the lesions. But it's a complex system. So both the lesions are quite complex as well as the aggregation of the lesions into a diagnosis. This is a nice study that I actually put in all my presentation because I think it's still very relevant. It's from 2004, quite some time ago. Let me try to make a, let's see if I can have a pointer. Yes, here. From 2004. but it's still very relevant. This is a study performed in England where they had a group of pathologists assess a number of biopsies, and they calculated the inter-observer disagreement or agreement. That ranges from 0, which means complete disagreement, to 1, which means complete agreement. You can see all the lesions that were assessed here. Yeah, you can see that the level of disagreement is pretty high. Then they had a visual feedback round where they showed actually, well, this is what we mean with acute glomerulitis, this is what we mean with arteriolar hyalinosis, and they had a new assessment by the same group of pathologists, and actually there's no change after this visual feedback round. So there's a maximum to what we as a group of pathologists can actually assess. Recently, we performed a relatively large inter-observer study or reader study in Amsterdam. There were 3 pathologists who scored 1,055 biopsies for the Banff classification, and we calculated the dissension or the lack of agreement, a lack of consensus on a per biopsy case. And this actually allows you to correlate this level of disagreement with outcome. So this is what you can see here. So time 0 means time of biopsy, and you can see here the Kaplan-Meier curves for the dissension score. In red here, for instance, for the glomerulitis score, you can see the cases where all 3 pathologists completely agreed, and those with some degree of dissension. You can see that actually for every of these scores, a lack of consensus associates with outcome. How that exactly works, maybe because the therapy is not aligning with the